Good afternoon, everybody, and welcome to this flash review class with Dr. Murali Bharadwaz. Today is December 14th, 2019, Saturday, and good to see Shivam Panchal and some of you online, Irfan Ahmed, and many more. Please welcome. Priyanka, Ammaji Nagreddy. Now, doctor, how is your preparation going on? This is the most frequent question asked by everybody across the world to you. If anybody asks, they ask the same question until January 4th. So I'm also asking the same question. How is your preparation going on? It should be going very high, bright. Am I right? Good. So, doctor, let's quickly pick up some 10 topics, 10 points about each of them. 100 points, Garbhadiram, half an hour mein discuss karenge. This is mainly to add a little spice to your preparation. This is Dr. Murali Bharadwaz, your everyday classmate in the NEETPG preparation. Now, what are you seeing, doctor? You are seeing periarticular osteoporosis. So you should remember, typically what you are able to see here is this is the osteoporotic zone, and this osteoporotic areas are there adjacent to the joints. So this is the classical feature of rheumatoid arthritis is what you should remember. So if the examiner asks tomorrow a question, what is the earliest clinical sign of rheumatoid arthritis radiologically? Juxta-articular osteopenia. You may also have soft tissue swelling, symmetric joint space loss, subchondral erosions, etc. etc. Now, what joints are involved, doc? Typically wrists, metacarpophalangeal, proximal interphalangeal, metatarsophalangeal, but not a distal interphalangeal, Distal interphalangeal joint involvement is a feature of osteoarthritis, psoriatic arthritis, but not rheumatoid arthritis is what you have to remember. Now, doctor, if you look at the X-ray hand, what can you see? You can see juxta-articular osteoporosis. Also, there is a subluxation of the metacarpophalangeal and interphalangeal joints. What do you call that as? We call it as hitchhiker's deformity. Hitchhiker's deformity is what you should remember. Now, what is Felty syndrome? Around 2 to 4% of patients who are having rheumatoid arthritis develop Felty. Right? Then, are you all guys having a good visibility of the screen? I hope so. Now, it is a triad, doctor. Rheumatoid arthritis, splenomegaly, granulocytopenia, ये तीनों को मिला के इसको कहते हैं Felty. Rheumatoid arthritis can also develop vasculitis. So these are the classical vasculitic lesions of ischemia. Now, doctor, why Felty syndrome you have granulocytopenia? Typically there is a splenomegaly. Because of that, there is a splenic sequestration of the granulocytes, and that leads to the development of granulocytopenia. Also, there are autoantibodies against the granulocyte growth factor, that is the GCSF, which is also responsible for the granulocytopenia in case of Felty syndrome. Guys, please drop a line in the WhatsApp study group that we have a flash live class Typically all these flash live classes are for about half an hour. The main idea is I want you to be in a highly motivated shape throughout the day while you are preparing. You should not feel low in mood at all. I will not let you to go into a low mode. That is the reason I will also become a student every day until the January 5th to add a little 2 ounces to your preparation by revising around 100 points from 10 topics in half an hour in the middle of the day. That is the plan. Now, doctor, anemia. One thing about anemia is anemia of chronic inflammation. That's what you see in rheumatoid arthritis. The more the inflammation, the more is the anemia. So C-reactive protein ESR, that is the reason people follow C-reactive protein and ESR. Excellent. Shwetaji rightly says, Kaplan syndrome is rheumatoid arthritis plus Kohlwerker pneumoconiosis. Beautiful. Right? Now, there can be a secondary Sjogren syndrome which can be associated with rheumatoid arthritis. How does it present? Whenever rheumatoid arthritis plus keratoconjunctivitis sicca, xerostomia, that is called Sjogren, secondary Sjogren. It can occur in about 10% of patients who have rheumatoid arthritis. One of the high-yield MCQ entrance is NEETPG exam. Is there any association with lymphoma? Yes, sir. Rheumatoid arthritis increases the risk of B-cell lymphoma is what you have to emphatically remember. Especially those who are having Feltis syndrome, they have a high risk of developing lymphoma. That is what you should remember. Now, doctor, tell me what is this that you are seeing inside the heart? दिल के अंदर आपको क्या दिखाई दे रहा? मास दिखाई दे रहा. कहाँ? It is seen in left atrium. So what is this left atrial mass? What are you thinking? You are also thinking what I am thinking, right? So here you can see the left atrial mass. When you do the ventriculogram, you are able to see the mass, the gross appearance of this mass. Then one more example, this is the left atrium. And here you can see in the left atrium, right atrium, this is left atrium. You are able to see a mass which is typically there in the left atrium. And also you are able to see even on 2D echo a mass which is dangling. What is this mass we are talking about? It is the cardiac myxoma, doctor. Cardiac myxoma. Now, one thing about cardiac myxoma, one of the favorite MCQs of the examiner is most frequent primary cardiac neoplasm. Examiner पूछे तो what is your answer? Cardiac myxoma. It is benign. It has stellate mesenchymal cells. That means star-shaped mesenchymal cells with a myxoid background, which is a classical feature. What is the most frequent location of cardiac myxoma? Left atrium. And it can produce mitral stenosis. But one hot question मैं बताऊं क्या? Paper out. Patient with cardiac myxoma present with fever, systemic symptoms. Lot of times you get confused because systemic symptoms dominate the clinical picture than the cardiac symptoms. That is the hot thing about cardiac myxoma. Barabar? Now, doctor, let's go to the next part of the story. What are you able to see here? Some histology you are showing us, doctor. Yes. This is the histology of vasculitis. What is this? It is vasculitis. Which vasculitis will show this kind of histology, doctor? This is another example of that vasculitis. This is a vasculitis, inflammation of the vessel. And this patient, because of this vasculitis, had a involvement with a granuloma which is formed in the periorbital area. This involves upper respiratory, lower respiratory, and also kidney. Come on, doctor, tell me what is this vasculitis? Punch, punch, punch. This is involving the periorbital tissue. This is leading to perforation of the palate. This is causing the ischemic necrosis of the nasal bridge. Tell me this vasculitis, mere pyare Bharatwasiyon. Vaginous granulomatosis is what you should remember. So how do you describe vaginous granulomatosis, doctor? फटाफट बोलो, 4 पंक्तियों में बोलो. Ray focal necrotizing vasculitis is vaginal. Prominent granulomas, which are typically centered on the vascular lesions. So you are able to see, no? Prominent granulomas, right? So prominent granulomas centered on the vasculitic lesions is the classical feature of the vaginous granulomatosis. This vasculitis, this granulomas, they can involve entire respiratory tract. You have to do a nasal biopsy. The renal involvement with necrotizing glomerulonephritis, middle-aged men, associate professor of medicine can get this. It has a poor prognosis, doctor. But what is the treatment of vaginas? Corticosteroids, cyclophosphamide. They are the typical part of the treatment. Khatam. Now, doctor, आपको कुछ दिखाई दे रहा है? भैया ये क्या है? किसका हिस्टोलॉजी के बारे में अभी मैं बात कर रहा हूं? What is this histology? This is another example of the same histological appearance of this condition, right? And on the peripheral smear, you are able to see these cells. Come on. Looking at that histology, looking at this peripheral smear, आपको क्या याद आता है? This is another example of the cells in the peripheral smear. So, doctor, this is follicular lymphoma. What is this? Follicular lymphoma. What is the favorite MCQ in the entrance? Tomorrow NEETPG में flash. पल्ली बटाने पॉइंट बोलो NEETPG के लिए. 14-18 translocation, overexpression of BCL2 protein. These are the things which are classical in follicular lymphoma. Follicular lymphoma, it involves lymph nodes, doctor, bone marrow. Older people, it is slow, it is relentless. In fact, follicular lymphoma इतना slow है, इतना lazy है, इतना dormant है, there is no role for any aggressive therapy. Always remember the role in leukemias or lymphomas. The more aggressive the tumor, the more vulnerable it is to the chemotherapy. The less aggressive tumor, you can't be able to give chemotherapy in case of follicular lymphoma because it has a very low mitotic activity. So mainly 2 points you will remember for the tomorrow's NEETPG. 14-18 translocation BCL2 protein. Barabar? Badhiya. Please drop a line in your WhatsApp group so that your friends also can join, doctor. I'm so happy. Just with a flash, without any notice, when we start the class, we have about 31 online classmates. Beautiful, doctor. डॉक्टर मुरली भरद्वाज आपको छोड़ेगा नहीं, आपके साथ पढ़ाई करेगा, सुबह से शाम तक पढ़ाई करेगा ताकि नो डिप्रेशन, नो एंजाइटी, नो टेंशन. अरे डॉक्टर टेंशन कई को, बैठना पढ़ना खाली एक ही काम है हमको नेक्स्ट अप टू जनवरी 4 तक. ठीक है. नाउ यू आर सीइंग दिस सेल्स. दिल लगा के देखो, पेरिफेरल स्मीयर में ये सेल्स दिखाई दे रहे हैं, इसको भी दिल लगा के देखो. ये क्या है डॉक्टर? ये है एक्यूट लिम्फोब्लास्टिक ल्यूकेमिया. व्हाट यू आर सीइंग आर द लिम्फोब्लास्ट इन द पेरिफेरल स्मीयर. अच्छा डॉक्टर, फ्रॉम वेयर डू द ALL अराइज? दिस इज द MCQ. एग्जामिनर कल के एग्जाम में पूछेगा, प्री बी सेल, mature B cell, which is the one which is affected? That is the favorite question. Gagan, Kuber, Shivam, Panchal, Priyanga. Please don't, you are all part of our WhatsApp study group. Please drop a line so that your friends can join. Now, doctor, hyperdiploidy Philadelphia chromosome T1221, T411. These are the translocations found in ALL. But shall I tell you one point? Shamelessly we have to do mugging. What is that, doctor? Abhi aa gaya. Prognostic factors, doctor. If you take last 15 years question papers now, examiner regularly पूछता है ALL का prognostic factors बोल के. WBC count less than 10,000, age 2 to 10 years, good prognosis, good. Female gender, good prognosis. Lymph node, liver, splenomegaly. If it is massive, poor prognosis. Testicular enlargement, poor prognosis. CNS involvement, poor prognosis. L1 type, good. L2 type, bad. But what is the dirtiest part of the story is, you have to remember this one. Trisomy 4, trisomy 10, trisomy 17. ये 3 चीजें डॉक्टर, these 3 things डॉक्टर, good prognosis, right? Then T1221 and tell AML1 good, 922 bad, 411 bad, MLL AF4 bad. You have to tell to examiner emphatically, hyperdiploidy is good. Time to remission, if it is taking less than 14 days, good. More than 28 days is bad. If this good, bad, good, bad, good, bad, we have to mug it up, doctor. Definitely आएगा कल के एग्जाम में. I am telling you now, leukemia, lymphoma के बिना अगर एग्जामिनर क्वेश्चन पेपर दिए तो मेरा नाम मुरली भरद्वाज नहीं है. ठीक है? हाँ. Now, doctor, you are seeing this histology. दिल लगा के देखो बाबू, ये किसका हिस्टोलॉजी है? अरे बड़ा बड़ा सेल्स दिख रहा है. क्या दिख रहा है? बड़ा बड़ा सेल्स उसको आंख के जैसे हैं. इसको देखे तो आपको क्या याद आ रहा है? Hey, that romantic night, you are lying down with your fiancée on the Goa beach, only glaring towards those beautiful stars in the sky, with the ocean making those tempestuous sounds of the waves. Oh, what a romantic night. Oh, romantic night ka starry sky dikhai de rahe kya? Where you and your girlfriend, only four eyes are watching, only one same sky and same stars. दिखाई देना पड़ता. Starry sky appearance is what you should remember. This is that starry sky appearance. Where do you get that, doctor? We get it in lymphoma, Burkitt lymphoma, Burkitt lymphoma. Now 10 points bolo, fatafat bolo, shamelessly bolo about Burkitt's lymphoma. It will be happening in African epidemic, sporadic, non-endemic, and AIDS also. Basically, whatever the form of Burkitt, all these are identical, and from where are they derived? B cells. Not pre-B cells, B cells. Only B cells, mature B cells, not pre-B cells. Expressing IgM. That is what you should remember, right? Now, doctor, Amma ji Nagredi yaad de rahe. Now, what is the oncogene in Burkitt? C-Myc oncogene. What is the chromosome? Chromosome 8. Where is the Ig focus, locus? Chromosome 14. So C-Myc oncogene is on 8, Ig focus locus is there on the 14, chromosome 14, you should not forget. So whenever 8-14 translocation occur, the C-Myc starts overexpressing. What is C-Myc? C-Myc is a nuclear transcription protein that lead to a sustained cell replication. And African form ko bhulna nahi, it is associated with Epstein-Barr virus infection. So this is the story of lymphoma. So please don't forget starry sky appearance. Now doctor, यहाँ आपको क्या दिखाई दे रहे हैं? Dense population of plasma cells. These are all plasma cells. इतने plasma cells bone marrow में plasma cytosis, if it is there, that is multiple myeloma. Now comes the question, doctor. Myeloma is a neoplasm of what? Is it pre-B? Is it B? What is it? Terminally differentiated B lymphocytes. इनका कैंसर होता है. The tumor of them is multiple myeloma. बराबर? Now, so this is very important, doctor. Tomorrow, NEETPG में one of the important issues for the examiner is what is the cell of the origin of each of the type of the leukemia and the lymphoma. Garma garam yaad rakhna. Barabar? Now, doctor. What does it secrete? Monoclonal Ig or a fragment, light chain or heavy chain? Typically, they have translocations. 25% of the multiple myeloma are due to translocations. Because of the translocations, there is an overexpression of FGFR3. What is that? Fibroblast growth factor receptor 3. FGFR3. So this is one important single liner MCQ. FGFR3 overexpression in multiple myeloma. So, doctor, what are you seeing here? What is this histology? Excellent. Nagreddy साहब बता रहे multiple myeloma translocation of FGF3. बढ़िया. That's how, doctor. Every topic के बारे में आपके pocket में 10-15 points रहना. All 953 topics. Nobody will stop you from becoming topper, doctor. Right? Image based हो, MLE हो, MLE के बाप हो, NEETPG हो, कुछ भी हो, The 953 topics I gave you the list, उसको गर्मा गर्म रिविजन करके 20 पॉइंट्स पॉकेट में रखना. हम बचपन में in our childhood we used to by heart and recite the entire social studies textbook, no doctor. Even NEETPG preparation also more or less like that only. So doctor, what you are seeing here is a node with small lymphocytic looking lymphoma. इसको कहते हैं small lymphocytic lymphoma. What is the importance? Why examiner is interested about this? Because small lymphocytic lymphoma is a B cell neoplasm. It is equal to your CLL. That is the reason. And from where does it arise? Circulating mature B cells, which express CD5. From them arises this small lymphocytic lymphoma. Mainly A point yaad rakhna, CD5 and small lymphocytic lymphoma. Very good. Now you are listening to the Aapke Farmaish Akashvani Panchrangi Karikram. आप सुन रहे हैं हाई यील्ड टॉपिक्स का 10 point revisions with Dr. Murali Bharadwaz in a flash show. So doctor, what is this? What is this neurocutaneous syndrome? So you are able to see these lesions, right? And you're also able to see these lesions. You are able to see a lesion here. And you are able to see a periungual fibroma. So what you have seen? Ash leaf hypopigmented macules. This is called shagreen patch. What is it called? Shagreen patch. Then periungual fibroma. इसको कहते हैं Coinan's tumor. What is it called? Coinan's tumor. So these are the typical fibrous cephalic plaque, facial angiofibroma, intraoral fibromas. So now doctor, let us quickly talk about. This is a patient with more florid lesions of tuberous sclerosis. Now what do you find in tuberous sclerosis in the brain? You will see the presence of subependymal nodules. What can you see? Subependymal nodules. So doctor, let us talk 10 points about tuberous sclerosis. Tuberous sclerosis, we have facial angiofibromata, angiofibromas. They're also called adenoma sebaceum. There are hypopigmented patches on the trunk. They are called ash leaf spots. And autosomal dominant is the inheritance pattern. And they also develop epilepsy, mental retardation, and all those tubers are what? Hematomatous nodules. Where are they found? Subependymal sites. And they are all, and what else a patient of tuberous sclerosis can have? Pancreatic cysts, renal angiomyolipomas, cardiac rhabdomyomas. They are all the things which are possible. And what is the real worry? What is the real worry? You are seeing a tuber. From this, astrocytoma can arise. That is our whole worry. Astrocytoma can arise from the tuber. Okay, doctor? Now, tell me what you are seeing, doctor, here. हो गया, story of tuberous sclerosis खत्म. Now, what you are seeing, bilateral acoustic neuroma. Tell me the neurocutaneous syndrome where you will find bilateral acoustic neuroma. We find it in neurofibromatosis type 2, not 1, 2. Barabar? You'll remember, right? Two acoustic neuromas in type 2. That's what you are going to remember. Tell me, doctor, what are you able to see here? You are seeing something. Yahan bhi something. What is this something? This something are capillary hemangioblastomas, which are the feature of von Hippel-Lindau syndrome. Classical question in the tomorrow's exam. Now, doctor, what you are able to see here? Herniated cerebellum. Tell me, which condition do you get that? Typically, cerebellum, A has cerebellum. Cerebellum has undergone herniation. Herniation. It is compressing. This is all brainstem, doctor. Right? So, it has undergone herniation. It is the feature of Arnold-Chiari malformation. That's what you should remember. Now, what can you see here, doctor? You are able to see calcification. Also, the choroid plexus has undergone enlargement. And you can see a leptomeningeal. Leptomeningeus means arachnoid, pia. So you are able to see a hematoma of leptomeningeus. So that is typically Sturge-Weber. In Sturge-Weber, what is this pattern of calcification called? This is called tram track type of calcification. So leptomeningeal angiomatosis, that is a classical feature of Sturge-Weber syndrome, is what you have to remember. That is Sturge-Weber. Maximum, these are the things asked about Sturge-Weber. Tell me, doctor, next topic. Chatpata, Garma Garam revision. Every topic 4-5 points for the examiner. Tell me, whose chest radiograph is this? देखते ही आप जंप करके बोलना. You are able to see potato nodes. Am I right, doc? Potato nodes. And what is this? Lupus pernio. These lesions are called lupus pernio, is what you should remember. And what is this? Granuloma. Granuloma. But this is a non-caseating granuloma. Non-caseating granuloma, lupus pernio, potato nodes with bilateral hilar lymphadenopathy. What is the diagnosis? Sarcoidosis. Sarcoidosis. Gagan Kuber. It is not dermato, it is sarcoidosis. Right? Good. No, don't withdraw. Don't withdraw. Mere pyare Gagan. Keep your answer. Your wrong answer is an inspiration for us. Kali hum nahi, hamare saath Gagan bhi hai. बोल के अच्छा फीलिंग आता है. Sometimes to make your roommate encourage you to study, inspire him. How do you inspire him? By giving some wrong answers, you should inspire him. Right? So, Gagan, don't withdraw your answer. So, doctor, sarcoidosis, common granulomatous disease. Lot of times, doctor, whenever a patient comes to you with एक हाइलार लिम्फेडिनोपैथी मीन्स आपको पढ़ने में मजा आ रहा है मगर पेशेंट के लिए मजा नहीं है डॉक्टर। टेंशन रियल टेंशन शुरू होता है। ये लिम्फोमा, ये मेटास्टेसिस, और इज इट टीबी, और इज इट सार्कोइडोसिस? क्या है डॉक्टर बोलो ना। देन व्हाट विल यू डू? You will do a CT guided biopsy of this lymph node and then you will look through the microscope. If it is a caseating granuloma, good news, laddu khilao. Immediately Pullareddy would say, laddu mangao, patient ko khilao. Kyunki TB hai to very easy to treat. So mycobacterial, fungal, anything can lead to that kind of a lymphadenopathy. Right, doc? Correct. Gagan Kuber confused with heliotrope rash with the lupus pernio. Right. Now, what type of granuloma? Small, non-caseating granuloma is sarcoidosis. Sarcoidosis initially involves lungs. It involves hilar lymph nodes, female preponderance, and typically what is the cause of death in sarcoidosis? Pulmonary fibrosis, cor pulmonale. That can very much happen in sarcoidosis. Now tell me, doctor, what are you seeing in this slide, in this histological slide? What you are able to see? Fatafat bolo. You are able to see histoplasma. So typically periodic acid Schiff stain is the one which will be staining the histoplasma. Histoplasma presents like clumps of organisms and it can lead to diffuse pneumonia. Involvement of the lung is the histoplasma. Now tell me, doctor, what are you able to see? What type of cells these are? These are eosinophils. They are significantly increased in number. That means we are talking about eosinophilia. Now tell me, doc, eosinophilia. Eosinophilia occurs in asthma, hay fever, pemphigus vulgaris also, eosinophilia, parasitic infestation. What is the favorite single liner MCQ? What is the eosinophil stimulating factor? Interleukin 5. You should not forget. Okay, doc? Now, ये क्या दिखाई दे रहे हैं बाबूजी? Basophils. Excellent. Gagan Kuber adds a very good point. Nitrofurantoin is the drug to be remembered leading to eosinophilia. Excellent, doctor. Basophilia. Basophilia, generally basophil count won't increase, doctor. If it is increased, it means you are worried. Generally basophils will be 0 to 1. If they are increased, chronic myelogenous leukemia, you should remember. Okay? Now, what are you seeing here, doctor? Lymphocytes, which are increased. So this is a typical peripheral smear of lymphocytosis. Lymphocytosis can develop in brucellosis, whooping cough, hepatitis, infectious mononucleosis, TB, and also chronic lymphocytic leukemia. Now, doctor, monocytes. Typically, monocytes are 1 to 3% of the total WBC count. They have abundant cytoplasm, large central oval indented nucleus. That is monocytes. They are larger than the other WBCs. आपको दिखाई दे रहे ना? indented nucleus, that is monocytosis. भैया मोनोसाइट क्या होता है? आप सबको मैक्रोफेज मालूम है ना? मैक्रोफेज टिश्यू में रहता है. मोनोसाइट is a circulating form of macrophage. So, where do you get monocytosis? TB, rickettsiosis, malaria, collagen vascular diseases, inflammatory bowel disease, they are the causes to be remembered for monocytosis. Now, what are these cells, Dako? Oh, mere pyare Dako, this is neutrophil. This is neutrophilia. Neutrophilia. You can see neutrophils with multiple lobes. Neutrophilia. So, neutrophilic leukocytosis. Typically, it is the interleukin 1 TNF which lead to increase in the neutrophil number. That is the neutrophilic leukocytosis is a feature of any bacterial infection, as all of you know very well. अच्छा, जरा रूमेटॉइड आर्थराइटिस का ट्रीटमेंट के बारे में बात करो. Methotrexate, it is a disease modifying anti-rheumatic agent and it is the agent of first choice for the treatment of rheumatoid arthritis. भैया एक methotrexate डिब्बा को भी देखे तो हम भूलेंगे नहीं, ठीक है? हाँ. Now, what are the other demands? Hydroxychloroquine, sulfasalazine, leflunomide. Examiner single liner MCQ क्या पूछेगा? बोलो. किसी को मालूम नहीं, खाली आप अटेंड कर रहे हैं ना डॉक्टर मुरली भरद्वाज के क्लास को, आपको ही मालूम है. Leflunomide is an inhibitor of pyrimidine synthesis and it can even be used as a single agent or in combination with methotrexate. अच्छा, leflunomide का डिब्बा को भी एक बार देखो डॉक्टर. ये leflunomide डिब्बा है, टैबलेट डिब्बा. Now this is what examiner is going to ask you. Leflunomide, once it enters, it become a metabolite A771726. Dihydroorotate become orotate by dihydroorotate dehydrogenase. Orotate will form uridine monophosphate in the de novo pyrimidine synthesis. And this enzyme, dihydroorotate dehydrogenase, is inhibited by A771726 is what you should remember. So this is what examiner is going to ask you. Leflunomide, mechanism of action of the drug. Okay, doc? Now, if it is a mild disease, mild, you can give hydroxychloroquine, sulfasalazine, especially whenever rheumatoid arthritis, very mild joint involvement hai to hydroxychloroquine. But if you are able to see a lot of erosions in the bone, then leflunomide. And then also biological targeted therapies which are disease modifying in rheumatoid arthritis. So what are they? There are 5 anti-tumor necrosis factor agents, doctor. Mainly it is infliximab. Infliximab is anti-TNF. भैया एक infliximab दे दो, एक डब्बा देखे तो आपको याद रहेगा infliximab. So doctor, how does infliximab act? Infliximab targets the soluble TNF alpha. That is how it acts like a anti-inflammatory. Now doctor, what is this drug? Rituximab. What is rituximab? Anti-CD20 is rituximab. Favorite single liner MCQ in the entrance, doctor. So अभी आपको समझ में आ गया ना? Preparation is very easy, doctor. Revision is most crucial thing. You should be very focused. What are the topics I am going to revise? 953 topics. खेलते खेलते रिविजन करो डॉक्टर, टेंशन काहे को लेता, बहुत टाइम है, 25 days टाइम है, but you should get one nice boyfriend or a girlfriend to sit with you. Don't forget, अकेले नहीं पढ़ना, 2-3 दोस्तों के साथ बैठ के, एक पढ़ते बैठता और एक डिप्रेशन में बैठ के सुनते ही रहता, और बीच बीच में वो सिंपल डिप्रेसिव को इंक्लूड मत करना आपके ग्रुप में, मेनियक डिप्रेसिव को ले लो, बाइपोलर वाले को, सडनली वो डिप्रेशन से उठ के मेनियक बन जाता ना, फटाफट 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 10 टॉपिक्स रिवीजन करेगा वो मेनिया मूड में, कैसा भी रिवीजन हो रहे हैं ना. हाँ, सो सिट विथ फ्रेंड्स, लास्ट 25 days, लास्ट मत बोलो, जिंदगी तमाम यही पढ़ते बैठना पड़ता. Tomorrow when you become MD General Medicine, DM Rheumatology, this is not the last 25 days for you. Now doctor, rituximab, anti-CD20 antibody, whenever patient is refractory to methotrexate, it is useful. It is useful for both seropositive and seronegative, but more efficacious in seropositive. Now doctor, what is seropositive? That means rheumatoid arthritis patient में 2 types रहता है doctor, एक rheumatoid factor positive, एक rheumatoid factor negative, accordingly called seropositive and negative. Okay? Now, oh, we reach it to the top of the page. 1 minute. हाँ. Next you are having anakinra. ये डब्बा देखे तो my point is, you will remember, you will get that conviction. अच्छा मैं डब्बा भी लिखा. So doctor, very important question. What is anakinra? Is the favorite question of the examiner. Anakinra, interleukin-1 receptor antagonist. Then abatacept, favorite MCQ. CD28, CD80, 86 antagonist. Tocilizumab, interleukin-6 antagonist. Please don't forget doctor. Finally, the NSAIDs like naproxen, only for symptomatic relief. They are not disease modifying. That is what doctor. देखा ना, 48 minutes में हम 100 points को revision कर दिया. Don't forget, tell your juniors, they don't need anything else. They only need Dr. Murali Bharadwaz. Ask them for their 2021 preparation to join NEETPG video library, doctor. 500 hours, every day 2 hours. 500 hours, there will be a live online interactive revision, and there are 1000+ hours, 2 lakh PowerPoint slides on the onlinembbs.com video library. So आराम से पढ़ो, खुशी से पढ़ो, हंसते हुए पढ़ो, खेलते हुए पढ़ो. This is Dr. Murali Bharadwaz, every minute, every time, along with you. Thank you. Have a good day.